All right, guys, I think we're going to go ahead and get started. Thank you so much for joining us today. My name is Heidi Ross. I'm the Director of Policy at NORD, and welcome to Project RDAC, the Rare Disease Advisory Council stakeholder meeting. We're going to get started by turning to our President and CEO, to NORD's President and CEO, Peter Saltonstall, for some opening remarks.
Heidi, thank you. I'm allowed to turn on my video, eh? I want to say welcome to everybody, and we're thrilled to have so many of you here today to help kick off this important meeting of Project RDAC. This meeting today is NORD's formal launching of this Project RDAC, or Rare Disease Advisory Councils. Our goal is to really optimize the existing RDACs and to assist other states in enacting strong RDAC legislation with a goal of having an RDAC in all 50 states. And so that's the thing I want to keep top of mind for everyone. That's the goal. And so I was thinking about it today, about making a couple of comments here as we started. Really, there's some real parallels between NORD that was established in 1983 as a grassroots movement with a goal of putting a spotlight on all those issues that were needed by the rare disease community, whether it be lack of therapies or lack of access or lack of really advocacy work that was going on back in those days. And ultimately, all that organization came together and culminated in the passage of the Orphan Drug Act. And I really see the RDACs as being sort of very similar to that. It's a real parallel of putting together these organizations at the state level, where it will allow stakeholders to have an opportunity to be able to come back and talk about those same type issues moving forward. So NORD is really excited about this project. We recognize it's a major investment, and it's an investment in time, but it's a really broad-based investment for the community. And so we're excited about it, and we hope you find the program enjoyable and helpful today. You will hear a number of things today about additional tools and things that we'll be doing as we move into the future and move forward with this project. And I also want to say that it would be impossible to do all of this if I didn't thank some of our sponsors who have really made this this whole thing available today. I want to thank Biogen. I want to thank Bluebird Bio, Boehringer Ingelheim, excuse me, CSL Behring, Horizon Therapeutics, and Vertex Pharmaceuticals, all for being key players in allowing us to be able to have this event today, make these RDACs happen. And so thank you all for giving us your time today and being here. Hope you find it an interactive, helpful session. And with that, I'm going to turn it back over to Heidi, who's going to make everything else work for you today.
Thanks so much, Peter, for those opening remarks. If everyone can turn off your video and put yourself on mute, that would help us out, because we're going to want only our panelists on camera. If you have a question, you can do so. You can submit that in the chat box. But let's go ahead and get started. So today's meeting is going to be broken into two parts: a moderated panel with audience question and answer session. And then later we'll move into breakout rooms where folks will be able to interact with and learn from people whose state's RDAC efforts are in a similar place. To get us started, we have a great panel to share the early successes and challenges of their state's RDACs. Their resumes are all incredibly impressive, and I won't be able to do them justice during these short introductions, but they're amazing advocates and champions within our rare disease community and playing leading roles in their state's RDACs. So joining us today from New Hampshire, we're grateful to have Representative William Marsh, a retired physician and a member of the New Hampshire House of Representatives, proudly representing Carroll 8. In 2019, Representative Marsh sponsored legislation to create an RDAC in New Hampshire and now serves as its chair. From Minnesota, we have Mrs. Erica Barnes, who is the founder and chairman of the board of directors of Chloe's Fight Rare Disease Foundation, in addition to serving as NORD's Minnesota Volunteer Ambassador. Ms. Barnes is also the administrator of the Chloe Barnes Advisory Council on Rare Diseases, named in honor of her late daughter, which was established in 2019. And from North Carolina, we're incredibly lucky to have Ms. Tara Britt. Ms. Britt is president and founder of Rare Disease Innovations Institute. She also currently serves as the associate chair of the North Carolina Rare Disease Advisory Council and Network. North Carolina created the country's first RDAC in 2015, and Tara and her colleagues Sharon were a critical component to that successful effort. So we have a lot we can learn from Ms. Britt and her state's RDAC effort. In Pennsylvania, we have Miss Marie Connolly. Miss Connolly is a rare disease patient herself and the founder of the Connolly Cushing's Disease Fund. Ms. Connolly also serves as the chair of the Pennsylvania RDAC, which has been in existence since 2017. Thank you all for joining us today. I'm going to start with Tara as the first state to create an RDAC. Can you tell us a little bit about how this idea of creating an RDAC in North Carolina came together 5 years ago? You're on mute, Tara.
Love the technology. Anyway, thank you, Nord, for hosting this. I think it's really important, and I'd love to share. Sharon King is a patient advocate in North Carolina. Her daughter had Batten disease, and I met her through working at the Gene Therapy Center at UNC, and we teamed up. It was her idea to have a legislative breakfast to form a council, because she wanted help for all rare diseases, not just her daughter's disease. She wanted help for everyone dealing with rare disease. So we teamed up and co-wrote some legislation, and with a lot of the help from supporters that we had in North Carolina, we worked the legislature. We kicked the breakfast off on March 25th, 2015, and by August the 5th, 2015, the bill was signed into law. It took a lot of work going to the legislature on a regular basis and talking to the legislators about how important this is, talking to them too about the economic impact of this on the state that rare disease takes. And I think they were, I made note cards for them so that they could go take them to other legislators and talk to them about it as well. And we found our champions, and then in January 26th of 2016, we had our very first council meeting. So we were extremely lucky and very fortunate to have a lot of people supporting us throughout the state, having champions in the legislature and having industry champions and rare disease patients and their caregivers and advocates. We all kind of work together to get this going.
That's wonderful. Marie and Erica, what motivated you to push for the creation of an RDAC in your own state?
Erica, do you want to start?
Sure, thanks, Marie. Yeah, I think the impetus for us to start the RDAC in our state was, and of course, we're going to hear this over and over in the rare disease space. Of course, things usually start grassroots because we know right now rare disease patients, even the rare disease community really was formed out of advocacy, just like Peter mentioned at the beginning. The whole fact that there is a rare disease community really was born out of advocacy. So the biggest impetus for us was really recognizing that the same barriers to care were being replicated over and over and over again across these patient populations. And it was really striking how many times if a patient with a rare disease tells their story, it's almost like you could just swap out the diagnosis and swap out the patient advocate, and you're going to hear nearly the same story, from delay in diagnosis to lack of specialists to travel time to get to someone who knows anything about your disease. So that was really the impetus for us to really address rare diseases collectively and in a systematic way.
Thanks, Erica. So Pennsylvania is a little different. Sharon from North Carolina was, unbeknownst to her, was probably one of the reasons how Pennsylvania got started. Joe Coyne, who is a parent who now is actually on our council, his son has Batten disease, and he went to his local legislator, Representative Marcy Topol, and very much like Erica just shared, talked about what that journey looks like. And at the time, this was in 2016, 2017, NORD was having conversations with different stakeholders, and Representative Topol had heard about these rare disease advisory councils and really pulled together stakeholders. Interestingly, there wasn't a lot of advocacy at large from individual patients. And once the legislation was introduced, there was a small group of us who were involved, and the legislation passed unanimously in our House and our Senate, and within probably about 7 months of it being introduced, was signed into law by our governor in 2017.
That's amazing. That's an incredibly fast success story that you guys were able to pull off in Pennsylvania. I will now turn to our legislator on the panel, Representative March. What made you interested in sponsoring RDAC legislation in New Hampshire, and then going so far as to become its chair as well?
Well, thank you, Heidi. The Rare Disease Advocates had organized Legislative Rare Disease Day. I think it was a luncheon, not a breakfast, but they got together an awful lot of people in the State House for about 3 years before we introduced this bill. And they happened to connect with me sort of by accident. I happen to have had some rare diseases in my family. And they also got the attention of Governor Sununu, who is very supportive of the idea of creating a forum for rare disease people to bring their concerns forward to the legislature. We set up our Rare Disease Council somewhat differently. When I wrote the bill, I wrote it as a legislative study committee. And consequently, we have 1 senator and 2 representatives on the council, and they've been attending quite regularly. I chair the council. We have not, one of the members needs to be reappointed because one of the men who was in that seat lost his election. So that is yet to be done. We've had some turmoil in the New Hampshire legislature. It was really a great way of getting the advocates directly together with legislators who would hear the specifics of things that we needed to address. And then going forward, we can take more small steps to address those concerns. We set it up without a termination date, so we seem to be set for the time being.
Yeah, that's really wonderful. You guys have each touched a little bit on the advocates that played a role in helping make this happen. How important was it to have a strong coalition supporting RDAC legislation as it was moving through the legislative process? Open that up to anybody.
I think it's vital. I don't think you can, how can you get legislation through without the patient voice being the center and representing what you're doing? I mean, the whole reason for the advisory council is to address the needs of the rare disease community at large, the patients, the caregivers, the whole community. And I think the patient voice has to drive that each and every time.
I'll kind of build on what Tara said. You know, I think that one of the things that is so striking in the rare disease community and what I think made such an impact on legislators is, you know, to hear those metrics from rare disease patients, right? We know it takes almost 7 years to get a diagnosis, and, you know, misdiagnoses and literally not having anyone with any knowledge of your disease, sometimes in your state. I think that those issues are not well understood outside of the rare disease community. So when legislators, whose job it is to, you know, care for their constituents and for the people in their state, hear about such an unmet need, it is so powerful. So those stories were so vital. And I think in addition to, you know, in the state of Minnesota, we built a coalition of 42 different stakeholders. And it was not just the patient advocates, it was also medical associations, hospital systems signed on. And I think that was also powerful to be able to send a message that, look, this is a, you know, this is a systemic issue that lots of different stakeholders feel should be a priority. So that was a big, powerful part of our coalition.
That's great. I was wondering if you guys would talk through some of what you guys see as some of your early successes. We know that Pennsylvania has been around for a couple of years. North Carolina was the first RDAC, but in Minnesota and in New Hampshire, you guys have only been, you know, signed into law in the last 2 years. So you can talk a little bit about what you guys see as some of your early successes. We'll start with Tara because she's the veteran of the group.
Thank you. I think, like Erica, we have a council of 7 people, I'd like to say, and it's made up of clinicians, researchers, patient advocates, patient survivor, a nurse in rare disease. And I'm very proud of the work that we've done. And as I was saying earlier, we have those council members, but we have about 35 to 40 people that attend our councils. Meetings. And so, I mean, some people fly in, we have a lot of industry, a lot of patient advocacy. We have clinicians like a pediatric geneticist that attends everyone who's vital in this. So it's not just about the council, but I always say it's about the community that, you know, the larger community that we are accomplished what we have. So one of our accomplishments that I'm very proud of, and we have a white paper out on our website, is on newborn screening. And we were trying to get 4 new indications, well, 3, but we got 4 added, indications through several years ago. And we wrote a white paper, and it was not advocating for newborn screening. It was actually just educating on the importance of newborn screening. And that white paper was adopted by the council, and it went to the governor's office. And with the help of a lot of the patient advocacy groups, the council, industry, the legislation went through, and an automatic inclusion as well, that we are addressing. And so we were very proud of that. And we've got a white paper as well out there on genetic testing. And this is not from just people in North Carolina. This is people, you know, that are interviewed that are specialists in these areas, as well as patient and advocates. And it's out there for anybody else, any other state. We're happy to share all of that.
And we'll put a link to those white papers in the chat box as well, so folks can look at them. They are a tremendous resource. How about you, Marie? What would you say are some of your successes in Pennsylvania?
Sure. So our legislation, I think Pennsylvania is a little bit of an anomaly when it comes to some of the other councils. Our legislation, as I shared, moved through pretty seamlessly. And actually, we've almost had the reverse situation where while stakeholders were initially brought in to talk through the idea of the legislation, we've really been engaging in stakeholder outreach since the legislation was passed. I would say a few of our successes is the legislation outlined that we needed to provide a report 1 in year 1 and a report in year 2. And so that forced our council really early on to really identify what some of the overall concerns, maybe misconceptions of the rare patient journey and the caregiver journey is. Then the second year we had to really discuss different reports of incidences. And so through there, we are proud of our year 1 and year 2 reports, which can be found on our website. We also noted that we needed to really do a patient needs assessment survey. And so with the phenomenal people on our council and their expertise, whether it's our physicians, our researchers, our surgeons, our epidemiologists, our caregivers, the patients, the parents of pediatric patients, we put together a comprehensive survey that we launched in September, recognizing that we're not necessarily housed in any particular place. We decided to look at the value of what our data was. We had an IRB review approval of it, so we're in that process. We've also spent quite a significant amount of time working closely and establishing excellent relationships with our Rare Disease Caucus. So we have really a go-to person in our House and our Senate in the Republican Democratic chambers. So that has really propelled and supported our efforts.
That's great. Thank you so much. Erica, what about you guys in Minnesota?
Yeah, so I'll start with some of what I would say are some of the intangible accomplishments that I'm seeing across the state of Minnesota, and then talk a little bit about some of the tangible things that we're working on. And we've only been in existence formally for a little over a year. So I think, you know, kind of an intangible, but one thing I'm really excited about and proud of is I really feel like that the state of Minnesota is really doing a great job of building collective consciousness around the rare disease community. You know, we know medicine is really siloed anyway, but there tends to be a lot of siloing, in the rare disease space. And so really starting to build collective consciousness in the state of Minnesota that there's a population out there that is the rare disease community, and sort of building this population health mindset and this idea that there are 7,000 different communities, but that collectively they make up a very distinct community with distinct needs. I'm also really proud of how we've been able to identify 4 priorities that we really feel are unique to the rare disease community. And we've incorporated that into our work plan, and also just the relationships that we've built, and starting to really start the conversation even within medicine, to really have a better understanding of the needs of the rare disease community. That was something that surprised me a little bit, that even among physicians and providers, there sometimes isn't as much awareness about the rare disease community as a community and as a population. So we've been working on that. We've done a lot of presentations in grand rounds. I've done numerous presentations. I get more invitations than I can even keep up with sometimes in presenting to different organizations and healthcare systems about the needs of the rare community. So that's very exciting. And I would say that that's our biggest sort of intangible, a little bit tangible. Also, we're working on 2 statewide surveys that we are currently in process of recruiting for. So if you are on this call and you're from the state of Minnesota and you have a rare disease, we have a patient survey that we're doing. We have almost 250 participants now that have taken the survey. We're always wanting to get it out to more patient groups. We are also launching a clinician survey to find out from medical professionals, what are some of the issues and the barriers that they're facing? What could help them as they try to meet the needs of the rare disease community? So both of those surveys. And I think that a couple of the wonderful professors that are helping to design that survey, they're not officially on the council, but they are helping us. I think they're on the call today. So shout out to Kathleen Bogart. I think I saw that she's on the call. She's doing a fantastic job and a big help.
And I think that's one thing that's really exciting about what you guys are doing in Minnesota, but really is what all rare disease advisory councils are trying to replicate, which is bringing in that broad community that has a touch point with rare diseases and get them all under one council, provide guidance, and to help inform the process from a perspective that might be different from your own. And that's why we really encourage diverse membership within these rare disease advisory councils. So you have the clinician, you have the patient, you have the caregiver, you have the academic researcher perspective, kind of all coming together at the benefit of the rare disease community. So that's really great. Thanks, Erica, for sharing that. And then Dr. Marsh, what would you say are some of your early successes in New Hampshire?
Well, in New Hampshire, a lot of our successes, I think, were based on the fact that the rare disease community had built a basis of support before we even established the council. So, for instance, we added 3 new diseases to the infant screening panel, but that was sort of happening before we even got the council started. We supported it, of course, but I'm not sure we should really take credit for it. We did have some legislative successes. We expanded telemedicine this last year. We combined some bills to reduce pharmaceutical costs into one omnibus bill. It was a strange year because of COVID legislatively anyway. Krista Gilbert ran a very nice survey for us. We had hoped to get patient listening sessions set up around the state, but I'm afraid COVID kind of put that to a halt, and we're trying to figure out a way of getting around that and perhaps doing it virtually. But our main goal was to create a forum from which new ideas could come forward, and I think we've really established that. We've established a connection with the legislature, which gives us a basis to continue to move forward as the years go on.
Yeah, no, I think that's really wonderful. I think telehealth has certainly been an emerging priority for those of us in the rare disease community. And it's really exciting to hear of your success in New Hampshire. They got a very broad bill out there to expand telehealth access, which should be very beneficial for the rare disease community.
Thank you. It was my bill.
It was Dr. Marsh's bill. So he is really a rare disease champion. So we're really grateful to have him, not only on this call, but really in his position within the legislature as well. I've been joking that if you've seen one RDAC, then you've seen exactly one RDAC, because they're all very different from one another. And for the health policy people, they're like Medicaid programs. You see one Medicaid program, and you've seen exactly one Medicaid program. But I think some of the lessons that we're learning out of RDACs can be applied across the board. So I was wondering if you guys would share a little bit about a barrier that your RDAC has come across and how you guys are working to overcome that. And I will reverse things, and I'll start with Erica on that.
Yeah, so I don't know if I like the word barrier as much as I like the word challenge / opportunity. But you know, obviously there are challenges that we're working to overcome, and I think the first one that comes to mind is just really threading that needle of addressing issues that are unique to the rare disease community and defining those outside of what's a challenge of just general healthcare, right? So we know that healthcare in general, there could be a lot of improvements that could be made, but how do we identify and address those challenges and make sure that we are finding things that apply to all the 7,000 rare disease communities. You know, we say that we're disease agnostic on the council. So we really want to make sure that the initiatives that we take up meet the needs of all of the rare disease communities. And, you know, I think one other challenge that sometimes comes up is that sometimes the center of gravity can pull maybe over to the pediatric world, right? And so we have to make sure that we've got that adult rare disease patient population perspective, and making sure that, you know, as the different groups of us that have different affinities for different issues, that we're really making sure that we stay broad, but yet do enough that's really going to make a difference. So that broad base covering all 7,000 rare diseases, but initiatives that are specific enough that they address real needs and make real change.
Insightful. Marie, what would you say are some things that you guys are working through, some challenges you guys are working through in Pennsylvania?
Sure. So I think you'll hear a lot of common themes amongst the four of us. I think that, you know, Erica definitely identified one of the challenges that our council has as well, and that is that there are so many different issues that you want to address, but it's you know, really trying to be thoughtful and strategic, and working within the stakeholder initiatives that are able to really call to light some of the rare disease issues. And what I mean by that is really working with, you know, our hospital association, our medical societies, so that we are working in alignment, and that we can be an additional support to them. I also think, and again, I think you'll hear this as a common thread, and Erica addressed this, it is especially for the rare community, sometimes time is not on your side, literally. And so it's making sure that your empathy is really trying to connect with the stakeholder group that you're really advocating for, but making sure that what you're able to do is going to outlive any one disease. I also think if we were looking and peeling back actual logistics, you know, for our council, the way that the act has been written, we don't necessarily live in a place while we have a dotted line to the Department of Health. That not living within a particular department or within a college or a research institution has created some different obstacles in trying to not only figure out where we are, but how can we establish funding? How can we go after potential grants? So I would say those are the two, you know, we live in very broad general terms, but then also if we get into the minutia, some of the logistics, or I should say lack of logistics in the act created a little bit of a challenge for us.
Yeah, that's really helpful to know. I think we know that there are 14 states that have established rare disease advisory councils, but we'd really like to see them in the other 36 states. And so that insight is really helpful. Tara, what are some challenges that you guys have gone through and worked through?
I think some of the challenges are making sure that we're staying on task with what the rare disease community perceives as their most important, what's most important to them. You know, we have clinicians and researchers and advocates and patients on the council, but it's just making sure we stay in touch with these communities, which we really try hard to do that. And as I told you, that Sharon King, my colleague on the council, you know, we were talking yesterday, sometimes we have to go back and let's look at the objectives we established the council with, because sometimes you get so big and you're trying to do so many different things. And you just you lose a little bit of sight of like, wait a minute, let's look back at what we have to report on, why we're here, and what we want to accomplish. So I think that's where we see some of the objectives. I know we're already setting our goals. We're getting things ready to have another council meeting virtually, and we're setting our goals for the next 3 years on what we want to accomplish. And so there'll be a very robust discussion, of course, about that. But that's why the patient advocate on any council, there's such a voice in that. What is important to this community, making sure you stay aligned with what's important in that community, and looking at your state structures as well. I think that's another thing that you looked at. I know early on when I first started this, and Sharon and I first started this in 2015, as soon as it was established, I asked the deputy secretary of DHHS, who I have a dotted line report to on the council, I said, I need to see the prevalence of what hits Medicaid by rare diseases in North Carolina. I need to see what is the prevalence of each disease. He said, sure, go talk to our IT people. And the IT people, after they laughed at me a little while after I asked that question, because there's no way to currently determine that. So anyway, I think we have a lot of challenges. I think we do with data as well. And it's just staying on task and making sure we're doing what's best for the rare disease community and what's most important to them to move forward.
Great. I think that the data piece is really important. Dr. Marsh, would you like to answer what are some of the barriers you guys are working through in New Hampshire? Being such a newly established council in the midst of COVID, I'm sure there are just a few.
Yeah, COVID is what killed us. We had met a couple of times and then COVID hit and shut us down. But I'm a little pushy, and we were the first legislative committee to be restarted after COVID. And with that, I think we regained our momentum, and at least by the time we filed the annual report, it looked like a pretty good year. Going to backtrack a little bit and add one more thing that was an achievement. I had forgotten about this, but we determined that we had a really good database at Dartmouth because it's the main referral center in New Hampshire.
I would agree that, one of the big challenges for us is that data collection, right? And I'm hearing it from the other RDACs that I feel like, it's so characteristic of the rare disease community. And I feel like all the smaller patient populations, there's not standardization across the way data is collected. Sometimes you're trying to compare apples and oranges. So, trying to crack that nut of how do we really get to what's the impact of all rare diseases, right, on our healthcare system and on patients. So that's a huge challenge. So if anybody out there has solutions, Minnesota would love to hear how to do a better job.
I'll chime in on that. I will tell you in my other role, as president and founder of Rare Disease Innovations Institute, I am working on a project with a congressman now at U.S. Congress regarding ICD codes for every rare disease, and we are about to launch in January. So hopefully, that NIH is helping us support this and some others. So hopefully we will have some additional data once we get this project underway.
One of the purposes of this conference is to generate new ideas. And it occurred to me while we've been talking, I know that our insurance department has a claims database sorted by ICD codes. And it would really be a straightforward matter to ask the Rare Disease Council, to ask the insurance department to query the database and answer some of these questions. I just need to get a list of ICD codes from some of the members of my committee, and then I could submit that request. And frankly, it never occurred to me until you guys were talking about this. So that's
Dr.
one new
Marsh,
idea.
In Pennsylvania, we actually, if you go our report to, we are very fortunate that in our legislation, we have representatives, a representative from the Departments of Health, Human Services, Insurance, and Education. And so given that the legislation asked us in year 2 to look at incidence and prevalence, again, that doesn't, and you're hearing this kind of common theme of not being able to really extract data. Our Department of Insurance, working with Human Services, did provide us some of the general data that's out there. And so our report too did take the the codes and cross-reference them with insurance data. So again, it's only what's public. It doesn't look at private insurers. But if anybody would be interested, it is unique to kind of see how that breaks out. But of course, as we know, the minute a new code comes out, there's still, 6 new ones that are still in the pipeline. I think the new codes come out in 2022, is it?
Yeah, and this project I'm working on is we've got a steering committee formed. It will be having a rare disease code for every rare disease at the federal level.
Yeah.
So we're hoping.
I know we have private insurers in our
Thank you. Would that be something? So hopefully we'll get this accomplished.
Yeah, in the chat, somebody's talking about patient registries. One of the things we've been trying to figure out how to do in New Hampshire is to set up a patient registry for ALS, because we had another bill that got tied into the bill that established our council. And this is hard to do without funding. But this is one of the things that we've been working on all year. We don't have a solution to the problem, but actually we're getting closer to a solution to the problem. So I think we may actually pull that one off.
One thing I wanted we've got a lot of people in the chat who are asking about getting an RDAC started in their state. And we know that there are 14 states that have started RDACs. We are hoping that we'll have 15 shortly. I know that Rep. Clates is on the call as well, who is our champion in Ohio and got their RDAC legislation through the legislature, and we're just awaiting Governor DeWine's signature. So thanks to Rep. Clates for that. But 9 of the last country's 15 RDACs were signed into law in the last 2 years. What guidance would you guys give RDACs as they're getting started?
I think again, Pennsylvania kind of went backwards. But I think as you're doing this, a representation of both chambers and both parties is essential, not just because of politics with a small p, but politics with a capital P, and keeping all 4 chambers engaged through the process, I think is really, really critical.
Tara, I see you nodding your head.
I agree. I agree with Marie on that. I think that's in terms. I mean, we don't have any legislative appointments on our council, and I'm glad we don't. But I think just the interaction with the legislators is, we explain, like, Marie, like when we would go to the legislature. Rare disease is bipartisan. This affects, everyone. So we made that point. I think that's why our bill flew through so quickly through the legislature, because it was bipartisan, and it was great to see, bipartisan support for a bill that affects everybody.
I also think it's really important to leverage the storytelling ability of the patient. And I think Erica touched on something. Pediatric tends to be what really is compelling, but it's very important too to talk about the adult diagnostic journey. And so when you're, of course you want substantive, quality legislation written, but really think about who's telling your story. I think that is very, very impactful.
And can I add to that? We were just talking about that recently, Marie, too, in North Carolina with our council. We want to make sure, especially we're getting you, I just identified a legislator that's pretty new that we're going to talk to about getting involved with our council, but all of us saying the same things on the council. So with whoever we're talking to, having that common voice for our council and having a message that's succinct, I think goes a long way. So that way, if one person sees a legislature, we're all saying the same things and getting our same points across.
Heidi, were you asking specifically for states that are trying are in the process of passing a council, or that have already passed it and are working on their initiatives?
I think either one. I think that there are several councils that are in the position of having already passed their legislation and are trying to get started in a tough COVID-filled era. But also for those new states that are just starting to pull together coalitions and wanting to do RDAC legislation, what recommendations would you make for them? Either way.
I would say I might be able to do a both and point. You know, I think one of the big lessons I learned is that, you know, as you're working to build out your coalition to get that legislation passed, a lot of that is going to guide the direction that you take once the bill is passed. So my biggest piece of advice to everyone is, as you're working on and asking the legislature to pass the RDAC legislation, you know, think about the ways that coalition building and, you know, the different messages that you take to the legislature, that's really going to be the foundation that you build out for the work that you're going to do once the bill is passed. The arguments that you make to your state legislature, and really, you know, every state is different, right? And every state legislature and every session is different. So, you know, perhaps in your state, one of your state, know your state priorities is, I think, another good point. You know, for example, in the state of Minnesota, during our legislative session, our governor really cares about making sure that greater Minnesota is represented. That's really important to the rare disease community too, right? You know, when you talk about getting a diagnosis or having access to a specialist, if you live in greater Minnesota in a rural area, that's difficult. So I think just, you know, knowing your state, knowing what's priority to your legislators, and knowing how that can apply to the council and to the rare disease community can be a really big and compelling thing. And I think too, just really driving home the sheer number, the number of people that the rare disease community makes. I mean, you know, 8 to 10% of the population. That's a lot of, those are all constituents of the legislature.
Yeah, I mean, with 25 to 30 million Americans having a rare disease, it can be very lonely to have a rare disease. But you think about that prevalence, and you're not alone. And that's NORD's motto: alone we are rare, together we are strong. So I think that is a good, you know, it's a good way to think about your coalition. Is you're not alone in this. This can be a really good opportunity for a lot of different people and a lot of advocates. So I think that's really great. It's wonderful. Dr. Marsh, what would you recommend?
Well, you know, the statement about the constituents is really important. It is about 8 to 10% of the population, and they don't just become your constituents, but they become your passionate supporting constituents. We've seen that. We've seen that. I don't want to tell medical stories here. I could, but people whose problems they didn't realize were being addressed, they really attach to you after that experience.
Sure. So one thing that's, you know, when we talk about every RDAC looking differently, we actually have a really nice representation on this panel where are your RDACs housed? And so we have two panels that, we have two panelists whose RDACs are housed within state universities. And we have two panelists whose RDACs are at least somewhat tangibly attached to departments of health, even if it's a very dotted line, as Marie said.
Yeah.
Can you guys talk about the advantages that you guys have had being based on where you're housed, or the extent to which you're housed? I'll turn to Erica to start us off from the university perspective.
Sure. Thank you. Yeah, so our RDAC is housed at the University of Minnesota, and actually specifically in the medical school. And I would say, you know, a huge value of being housed in academia is, gosh, just the access to academics, to research, to, you know, innovations, to, you know, people who are working to really advance medicine, and to the researchers. The University of Minnesota Medical School is, I think it's in the top 5 of the largest medical schools in the United States, for sure top 10, but I want to say top 5. And then also one thing, so I knew that it would be advantageous to have access to, you know, academia, but the one really cool and exciting thing is the access to the students. You know, I bumped into a PhD student in bioinformatics. He was a complete stranger, just an acquaintance of a friend I was with. And long story short, he has switched his PhD dissertation to rare disease, something in the rare disease space. And so, and there's students that are starting student organizations for the rare disease community. So really the energy of students has been so exciting to me. And I think there's a real understanding and a real energy around understanding that the rare disease community has been underrepresented in medicine, and it's an equity issue. So I think being in academia, just watching the next generation of researchers and clinicians in the future has been really cool.
That's great. What about you, Tara? You guys are housed at a university as well.
Correct. Since I co-wrote the bill, the dean of the medical school at UNC agreed to house it there, and I was very grateful for that. Erica, exactly the students. It's so exciting to see other people jump on board. Another thing that I think really benefited us being housed at the university is, getting the word out to all of these different doctors, these clinicians and researchers that even at your own university don't know each other, and they don't know they're in the, this person's in the rare disease field. The council was so critical in connecting people like that. Hey, we had people that wrote grants with each other that had not known of each other before the council. So it was connecting not just people at UNC, but we also have representation from Duke. And you all know that Duke and UNC on that basketball court are big rivals. But when we come together with the Rare Disease Council and we have membership from both, it is amazing just the collaboration that has spun out of this. It's thrilling. And I was so glad, speaking of NORD, I spoke at the UNC students NORD, I think their first meeting, and NC State's NORD's first meeting. So that was really good. And to see these students getting really excited about rare disease, I think is I think it's exciting.
No, that's great. So Marie, you guys have a very narrow line to the Department of Health. How has that been helpful or been a challenge to overcome and work through?
So our council, we're a bit of nomads, but I think, we have used that to our advantage to really look and envision what we want to be in a few years from now, and that would be our own 501c3. So we started a collaboration with a organization, a foundation for enhancing communities, which has become our fiscal sponsor. So while we do not live within the Department of Education, we are established to receive donations, to work on grants. What's also unique about this is that we all know within state government and within big bureaucracies like research institutions, sometimes when you do a project and when you have funding, you have to go through certain RFP processes and you have to deal with different staff issues. We've been fortunate to be nimble. So, given the fact that we were able to have a grant and we wanted to work on a website, we interviewed 3 vendors and made a decision and signed off within, 4 weeks. Anybody who's worked in state government knows that is never going to be possible. Having served as a trustee for the Pennsylvania State System of Higher Education, higher education institutions have a bit of bureaucracy within themselves. So we're really fortunate that we don't necessarily have to follow that kind of guideline. I would say that the challenge is being embedded in an institution is, our advocacy, our legislative support, our marketing, any type of budget negotiations. Because we're not embedded anywhere, it's incumbent upon us. So, again, pluses and minuses. Again, it's the rare community. We're used to, I said it before, we're used to making lemonade out of rocks. So, we figure it out.
We are nothing if not scrappy, that's for sure. All right, Dr. Marsh, what about your council?
Well, we're set up as a legislative study committee. So technically we're part of the legislature. That gives us a inside track to getting in touch with legislators and getting things done. But we have a number of members on our council who are in academia. They come down from Dartmouth or Zoom down from Dartmouth nowadays. So while we're not housed there, I think we have a connection to that community, and that's worked out reasonably well. We're also not officially under Health and Human Services, but one of the good things that came out of COVID is the legislature had a shortage of IT support, so we got transferred to IT support out of Health and Human Services, and that sort of enhanced that connection too. So it's sort of a strange beast the way it's set up, but it seems to work for us.
That's great. So we've got some good questions that are coming in from the chat, and one of them is: Are your state's RDAC meetings open to the public? And if so, how do people find out about them? I think we've been sharing some websites, but are your guys' meetings open to the public? And how would you recommend folks engage with your RDACs?
In North Carolina, they have to be open to the public because it's under the Sunshine Act. So we publish that on the website. I did not, I published the virtual meeting we had as well, but we just didn't have as many people to attend that. But yes, and like I said, we have 7 members, but we usually have 35 people in attendance. So a lot of interest.
Since we're loosely affiliated with the Department of Health, we are sunshined. Again, COVID kind of unfortunately took a turn for us. We are hoping to do some regional listening sessions and turn those into meetings. So, but yes, given COVID, we have the ability for people to link and Zoom in.
Yeah, we're open to the public in New Hampshire too. And one of the neat things is sometimes we have patients with particular rare diseases come to our meetings and realize there are other people who actually have the same thing. And then they may not feel the need to come back because they've made a connection. But that's been kind of fun, actually. It has worked out very well. The downside of being open to the public is we got Zoom bombed last month. So, you know, it's not all good there.
And echo what everyone else says. Yes, absolutely open to the public and welcome. People welcome. COVID has made it a little bit of a challenge to just, you know, get that information out there and get the web link, but also makes it easier in some ways for people to, you know, Zoom in from anywhere in the state. So yeah, definitely want input and attendance by as many people. I saw that our website got put in the chat. So that information is available to anybody on this webinar.
I think that's something that COVID by default has really opened up and become more accepting. And I think, again, when you're looking at the rare community, it's not just the rare patient, but it's the caregivers and the family. And so, again, like North Carolina and Minnesota, you know, our state is fairly large and we have some really rural areas. And so the ability, I think, for us moving forward to become more attentive to the needs of the patient, you know, this acceptance of now a virtual setting, I think will really allow patients to feel more inclusive. And I think, again, it's sometimes hard to see an upside of COVID, but I think that's the acceptability of people becoming, being able to access remotely, I think is a great thing.
Yeah, no, I mean, we know for the rare disease community, it can be hard to get to the state capitol or an academic research center to get to a meeting. So the ability to Zoom in, I think, between that and telehealth, I feel like those are the only silver linings I really found thus far about COVID, but we'll take what we can get, I guess. Another question that came in is, you know, a lot of small rare disease advocacy organizations don't have a chapter in every state. They're a national organization. What would you guys recommend those national organizations to do to provide feedback into your state's RDAC? Recognizing that each state's needs are different and each community's needs are different, but that, you know, a national perspective on some things might also be able to be informative to your work. Tara, can I start with you?
Sure, let me think about that. So I work a lot with the national level and state level folks. And most of the smaller state levels, I think there are, or at least the ones I've worked with, are pretty savvy. I mean, you know, I think they've been pretty savvy to connect with the larger level, higher level foundations. So I've seen, especially over the last couple of years, I've seen a lot more collaborative work going on between these smaller groups and working with the larger groups, because, you know, it's powerful when you work together. That's, you know, but if you hear the groups, especially the smaller groups, they'll come and say, you know, we feel so isolated, or we feel so, you know, part of our role here, I think within the states, is to connect those groups as well. I mean, I think we have to do that, and for the larger foundations to help support the work of the smaller foundations. But I think working together, you know, I think that accomplishes that.
Okay, what do you think, Marie?
I think, you know, one of the challenges we have in Pennsylvania is really trying to identify all of the different smaller organizations that are out there. And, you know, we're grateful for the stakeholder and collaboration we've had with some of our state organizations, but it's really, you know, because again, this is really a grassroots effort. And within the rare community, you know, when you're looking at populations of where only maybe, you know, 5 to 10 people in your state even have a disease, it's how do you really engage and reach out? And, you know, our hope is that working with the physicians in the hospitals, we're really able to push down that information to make sure that we're really, you know, like Tara said, just, you know, making sure that someone doesn't feel alone. And that's really what, you know, one of the overall goals I think of all of our council is that the collective rare, and again, that's NOR's MO, is to make sure that together they're heard. So
Yeah, Heidi, I can go next. And this is maybe taking it a little bit of a different direction and hopefully not getting in the weeds too much for the state of Minnesota. But, you know, one of the things that we have identified as a council, and it's a little aspirational, but we're hoping that in 2021, we can make some progress on this. You know, one of the huge benefits I see when I hear the word, you know, a rare disease organization that's national, I just assume that organization is going to be a little bit more mature. Like you're a more mature patient organization group. And I think one really powerful thing that I would like to see done is one of our pillars is the acceleration of research on our council. And the way that we're conceiving of that in one sense is, you know, you can accelerate research by really supporting the organizational health and the organizational maturity of patient communities. So one of our real goals is to kind of connect these maybe smaller, more what I call emerging patient communities. You know, for example, maybe a mutation that was just identified, you know, 3 years ago, a genetic mutation. And so that community is really trying to figure out, what do we need? You know, do we need a Facebook page? Do we need a registry? Do we need you know, what do we need? And my dream in Minnesota is to connect some of these organizations that are mature and have been around for a long time, and get them to engage with these smaller patient communities so that those smaller patient communities can learn what they need. You know, I always disclose this because I think it kind of shows how difficult this can be. I am kind of embarrassed to admit, but then I don't blame myself. You know, I think it was 5 years after losing my daughter that I even knew what a natural history study was, right? And that I even knew, oh, that's something that my daughter's data could contribute to that. So, you know, helping these looser, smaller patient communities really like incubate. So I don't know if that's exactly what you're asking, Heidi, but I see some of you people that represent more mature patient groups, you could really help sort of almost like a mentorship.
Oh, no, I think that's really great. You touched on something briefly, which is one of the questions we got in the chat box, which was, to what extent do you guys engage with social media as part of your RDACs? You guys, something you've explored? Are you doing anything with that?
I'm happy to share. And I'm very grateful because the person who handles all of our social media and communications is on the call, Stephanie Fisher. She's a member of our council, and you know, we actually created social media guidelines you know, for the council and identified, you know, the suggestions of what a council member should post in terms of identifying themselves as a council member versus what an individual is. We're very, very cautious about putting out any type of surveys unless they come from very specific sources. But I mean, I think, you know, in this day and age, you have to engage. Right now, we're only engaged in Facebook and Twitter. But you know, it's one of the only ways that we're going to be able to really reach, you know, any constituency. Also, it's a great way to help us co-brand with some of our key stakeholders.
That's great. Tara, you were shaking your head. What were you?
Yeah, we've not been as successful with that in North Carolina. As a matter of fact, that's on our, when we were talking, when groups of members of the council and I were talking the other day, that's something they want to address in when we have our next meeting, because just because of limited resources, basically. I mean, I was lucky with the website. So I provided all the content for the website at UNC, and I had all these different departments who had rare disease folks helping with that website, which has been good. And now we've taken it actually off to its own .org site. And I've got somebody volunteering putting the content out. But we've got to get a lot better along, like with Facebook and social media, and we realize that. It's just the bandwidth of people, you know, of their time to do it.
I would agree with Tara. So we're just now getting into our second year of the council. In the first year, we really wanted to build out the bones and make sure that we knew what we were doing, and we had some really clear goals. I would say that the one way that we for sure realize and recognize that we need to utilize social media is for survey recruitment, for our patient survey. Again, it's very important to me that we have diversity of participation, and I recognize that there are lots of rare disease communities that don't have capacity to have a 501c3, and it may be even difficult to reach them through the hospital systems. So we do have a social media campaign really focused on getting our survey out to as many patient populations as we can. So we're just now building that out. So
if I could tack on to what Erica said, I think she brings up a really important point for all councils is, you know, with Pennsylvania, we're, you know, in year 3, and we did not have any type of social media presence until about almost the beginning of year 2.5. And a big part of that is because, like Erica said, you need to make sure that you've, at least in our opinion, we wanted to establish ourselves, build that credibility, kind of like building a house. We wanted to make sure that that foundation was strong. Before we showed anybody what the house looked like, we wanted to make sure it wasn't going to cave in. So, you know, we're still kicking the tires a bit, but, you know, we definitely made sure that, you know, we established ourselves and are credible. And, you know, we're not afraid to make sure that we sometimes will ride the coattails of some really stronger stakeholders in their particular initiatives, because we're new and we're trying to establish ourselves. But I think it's really important, before you just go out there and start, you know, posting, make sure you know what you want to be and who you are.
I think that's a really great point. Another question that's coming from the chat that I think is really helpful is, what guidance would you guys give to folks who have gotten an RDAC through their state legislature? It's been signed into law. What were some of the first steps that you guys taught that will really set you guys on a good pathway for success?
I'll start. I think, so you're asking, as soon as we started as soon as the legislation was passed, what were some successful things? I think it was critical to pick the right people to serve on your council. I just think that was critical. The chair and myself, we really researched that, and I was thankful for him because he was chair of the faculty senate at the time at UNC. And just to pick the people that, it's easy when you when people are on councils, they want to be, but they're more about, oh, I want to focus on my disease, or researchers. But we chose people that we knew would care about all rare diseases and they could see past. So I think that's critical. to creating a successful council, just making sure everybody's in it for the right reasons.
That's great. Very good.
I'll look at it from a different approach. And again, I think if you would have asked any of us, we wouldn't have even thought of doing this on our own. But again, in the beginning, when we were closely affiliated with the Department of Health, when we convened our first meeting, they actually had paid for a facilitator. So at the time, there was a Lyme disease task force, and there's an organ donation task force, and whatever other task force are out there. So there was a professional facilitator who came in. And while the professional facilitator, that funding stopped from the Department of Health, our council figured out how to continue to fund them. So again, funding may not, be available, but perhaps someone would consider doing some pro bono work. But having that outside facilitator to really help us move and guide and step and contemplate, and then more importantly, pull all these great, brilliant minds together was honestly one of our hidden gems.
That's great advice. That's fantastic advice. What about you, Dr. Marsh? What would you recommend?
I just got an email from somebody about one of the issues that we were trying to deal with in our council. So I'm sorry I got slightly distracted there. Could you repeat the question for me?
No, I was saying for a new RDAC that's just getting started.
Oh, yes, thank you. Yes. I just needed the prompt. I didn't remember. What we did in our second or third meeting is we got Sharon King from North Carolina to call in and talk to our whole council. Yeah. And that did two things. First of all, it focused us on some of the things that these councils do. And second of all, it made us feel good that we were already doing some of those things. So that was tremendous.
Yeah, that's great. What about you, Erica?
Yeah, I think, sort of related to what Marie said, but, even if you don't have the capacity to hire a facilitator, I think everybody's impulse is to jump right into the work, right? And to just start. And we have a group of some of the most, I'm so blessed to have some of the most brilliant and also some of the most passionate and humble people that I've ever met around the table at my council. And so I know that we all want to jump into the work, but I think really spending time on that work plan. And again, I think for the first year, and I say it and I don't always live by it as the council administrator, but really, I think that first year I tried to really drive home the mantra, if you can't measure it, you can't improve it. So spend some time getting your own measurements so that you can measure yourself against that baseline, whatever they be. So spend time on those metrics and spend time on just sort of building out that work plan. I'm really proud of the fact that we identified 4 pillars as a council, and what we see is 4 initiatives that are really beneficial to multiple rare diseases.
So we are nearing the end of our moderated session. We've seen a lot of chats about how can we get involved and what are some of the resources that NORD has available. I'm pleased to share that as part of Project RDAC, NORD is going to be developing and releasing toolkits, including kind of a coalition building one, a legislative one, and a post-legislative RDAC implementation toolkit. We plan to host webinars, convene additional meetings to support ongoing RDAC work. In January, the first toolkit on how to build a coalition for an RDAC will become live. And also mark your calendars for July 2021. We plan to host another RDAC stakeholders meeting to gain insights from a successful 2021 legislative season and another 6 months of effective RDAC work completed. So there's a lot to come. We are going to first, before we head to the breakout session, we're going to hear again from NORD's president and CEO, Peter Saltonstall.
Hard to follow that great conversation. I really want to say a sincere thanks to the panelists. It was really insightful to hear your experience in putting these together. And I have a number of notes I'm going to follow up with some of you on, as a matter of fact. But we, again, really thank you. It's helpful to the community to hear from people like yourselves who have gone out and done it. It makes the pathway forward much easier for those that want to follow. So again, a sincere thank you for providing clear, concise really, really good information this afternoon. So I also want to say, I want to echo what Heidi said, a lot going on. We really look forward to partnering with you all as we move forward for the RDACs moving into 2021 and beyond. And just really, again, a very sincere thanks to the panelists. I also want to take one more minute to say thank you to our sponsors. I think that Biogen, we still there? I lost my screen.
We still have you, Peter.
I lost my list of sponsors, Heidi. So I know it's Biogen, it's Biogen, and it is CSL Behring, and it is Horizon, and it is Vertex, and it is Boehringer Ingelheim, and I think there's one more.
Bluebird Bio.
Bluebird Bio. Thank you. I'm sorry. I'm like Mr. Marsh. My memory is bad late in the day here, especially. So I want to thank all of them for their funding support to help make this happen, and for making us, allowing us to be able to put on this program this afternoon. So look forward again to working with all of you on this important project as we move forward. So thank you, and I hope you enjoy the rest of the sessions this afternoon.